This video presents some of the material from Chapter 15. The eclectic approach basically uses bits and pieces from each therapeutic approach, depending on what the client would benefit from the most. Maybe the therapist will address problem behaviors using the behavioral model, and then tackle some relationship problems through more of a psychodynamic approach. It's probably most common to see behavioral approaches combined with cognitive approaches, and that's basically the approach of cognitive behavioral therapy, or CBT, which is widely regarded as one of the best treatments for many problems like anxiety and depression. Carl Rogers developed the humanistic therapy style, which is also known as person-centered therapy. It's also called humanism as a subdivision of psychology. Each person, or client, is the focus of the treatment. The client actually directs the therapy session. Rogers believed that therapists shouldn't take over, but should allow the client to have the control. He believed that the client needs to take responsibility for identifying and discussing their own problems. Rogers believed that we are all born with the potential to be great. Not great in the sense of fame and fortune, but great in terms of being the best version of ourselves. He thought that people can get knocked down to the point that they can't thrive, but that a caring, genuine, empathetic therapist can bring them back up to the point that they can then self-actualize and reach their potential. What's the difference between empathy and sympathy? You can more easily feel sorry for someone, but when you empathize, you actually put yourselves in their shoes. You feel their pain. You don't merely recognize that it's painful. As you can probably imagine, to effectively treat people, healthcare providers have to protect themselves and their own emotions. If they become too emotionally involved with every person they treat, they might not make it through the patient's setbacks. But Rogers thought that showing true empathy was the only way a therapist could truly help a client. When the therapist accepted and understood the client, that was what allowed that client to gain a better perspective of their true self. Rogers, the guy with the glasses on the right in this picture, influenced a lot of pastoral counseling methods. But one other great contribution he made was with his work in active listening. I'm sure y'all have heard that term before, active listening. What does that mean exactly? To be all in as a listener, really paying attention to the person, not allowing yourself to become distracted or to think about what you plan to say next. How do you convey that you're actively listening? First, be empathetic and genuine. Repeat back what they say, either by paraphrasing or restating what they said verbatim. Watch your body language and posture. If you're slumped over or frowning, that doesn't convey that you're invested in this conversation. Try using head nods, uh-huhs, and be purposeful with the tone of your voice. Ask them open-ended questions and then summarize what you think you understood them to be saying to make sure that you're truly understanding. In this chapter, we cover behavioral therapies, where the therapists focus on problem behaviors and try to find ways to condition healthier behaviors. One type of behavioral therapy is aversive conditioning, when a nasty stimulus is introduced that will hopefully turn the person off of a co-occurring undesirable behavior. One of the most common types of aversive conditioning is using antabuse to treat alcoholism. Antabuse is a drug that, when consumed with alcohol, makes the person feel very sick. So does psychotherapy actually work? Hans Eysenck published a study in 1952 that showed treatment did in fact help about 2/3 of the people who sought help. But he found that about the same number of people who didn't get any help at all also improved. Just the passage of time seems to heal a lot of wounds, something known as spontaneous remission. There's still debate about whether or not therapy actually helps, but more studies have been done, even better, more controlled studies, and then meta-analyses have been performed to compare the results from multiple studies. One meta-analysis of 475 studies done in 1980 showed that the average therapy client does improve more than about 80% of those who were on a wait list and did not receive treatment. Studies and meta-analyses have also shown that relapse rates are less if a person has received treatment, so that's significant. I think most agree today that psychotherapy does help, especially in terms of equipping people to resist falling back into bad habits. Again, relapse rates are lower among those who receive treatment. But there aren't clear and absolute winners of which therapeutic method is best for a specific disorder. Specific individuals might benefit from one therapeutic technique and not from another. We do know that behavioral methods are probably needed when there's a clear problem behavior or for things like phobias. CBT is very effective in treating anxiety, PTSD, depression, and ADHD. Psychodynamic therapies are good for anxiety and depression, and in fact may be just as effective at reducing depression as CBT. And family therapy is excellent for alcoholism and anorexia. There are some other disorders for which one treatment seems to be at least somewhat better, but again, it's not so absolute that we can say to people that if you have X disorder, you should do Y therapy. Most therapies share common characteristics, so it really comes down to finding something that works for the individual. Recognizing this, many therapists don't specialize in any one type of technique, but tailor their treatment plan to the individual person, choosing something from psychodynamic approaches here and something from a behavioral approach there. That's the eclectic approach. All of the biomedical techniques listed on this slide are different from one another, but their shared and overall goal is to change the brain's functioning and/or neurotransmitter activity, either through drugs or electrical pulses. Drug therapies are used a lot today. When their usefulness in treating psychological problems was first discovered, asylums and mental hospitals almost disappeared because as long as people stayed on their medication, they could function reasonably well in society again. These meds are very effective but are also controversial. Some of these are very addictive, and withdrawal and side effects can be significant. They also don't correct ongoing maladaptive behaviors. If you have an anxiety disorder and you simply pop a Xanax every time you feel the tiniest bit overwhelmed, that's probably not going to change things for you long term or help you develop your coping skills. Here are some commonly used drugs: antipsychotics like Thorazine, which you might prescribe to somebody with schizophrenia who's having hallucinations; antidepressants like Prozac; lithium to stabilize moods, often used with bipolar disorder; and benzodiazepines that treat anxiety. When we talked about schizophrenia, I mentioned that those with positive symptoms can often recover the most with drug therapies. So what are the positive symptoms again? Adding something that people typically don't have, like hallucinations, delusions, psychosis, and agitation. Medications like the ones you see listed here can help counteract positive symptoms like those we see with schizophrenia. Antidepressants work to even out and elevate moods by actually changing the amount of certain neurotransmitters. Serotonin is a very important one. Along with dopamine and norepinephrine, problems with serotonin levels can be found in a lot of different disorders. Depression in particular involves low levels of serotonin. SSRIs are commonly prescribed, and they work by preventing or inhibiting serotonin from being reabsorbed by the firing neuron. Remember the reuptake process? Normally, when a neuron releases serotonin and sends it to a receiving neuron, any leftover serotonin will be reabsorbed by that original firing neuron so that it's not left floating around in the brain. Because people who suffer from depression don't have enough serotonin in their brains, these SSRI drugs work by preventing serotonin from being reabsorbed. They prevent that reuptake process. So these drugs selectively inhibit the reuptake of serotonin, leaving it floating around in the brain and boosting the person's mood. Antidepressants don't work overnight, taking weeks to months to effect significant change. So drug companies are working to eliminate the hallucinogenic side effects of drugs like ketamine, a party drug and anesthetic, since it can relieve depressive symptoms within hours of taking it. But as of now, people still experience hallucinations with ketamine. Antidepressants are also used to treat chronic pain, anxiety, PTSD, and OCD. Mood stabilizers, like the ones listed here to treat bipolar, not only even out and raise up moods, but they can also prevent future extreme fluctuations in mood. That's one reason why it's so important for people to continue taking their medications, even after the worst of the episode has passed. Obviously, anti-anxiety medications like Xanax are used to ease anxiousness, but they also just make people feel good. I've heard people refer to these as their happy pills. Both anti-anxiety and antidepressants are sometimes used to manage long-term chronic pain. Transcranial direct current stimulation delivers a very mild current to the scalp, but studies are still evaluating whether it's enough to be an effective treatment for depression. Repetitive transcranial magnetic stimulation sends a magnetic wave to the brain's surface only. It seems to be much more promising because it does not cause any memory loss. People who receive this treatment might suffer from some headaches after treatment, but most do not experience seizures. Researchers don't think the number of seizures exceeds that of drug therapies. You may not have known this, but medications can cause people to seize too. In 2018, the Texas Tech University Health Sciences Center and Laura W. Bush Institute here in Amarillo raised money and bought one of these machines for Amarillo. With deep brain stimulation, electrodes are placed in specific places in the brain, and then a pacemaker sends electrical impulses to those electrodes. This is not only used to treat depression, but is also sometimes used to treat OCD and Parkinson's disease. With Parkinson's, this treatment can help control their tremors. With psychosurgery, surgeons remove or destroy brain tissue in specific areas. They made horror movies about the procedure known as the lobotomy. Basically, surgeons would just sever the nerves connecting the two sides of the frontal lobe, separating the two hemispheres. We've talked in this class about how important that frontal lobe is. It defines our personalities and helps us make decisions and solve problems. People who had a lobotomy were certainly cured of their worst symptoms, most of whom were given the lobotomy because of their out-of-control violence, but they were left almost like vegetables for the rest of their lives. After all, their brains were cut apart. Lobotomies are no longer performed. However, microsurgeries are sometimes done in very small, isolated sections of the brain. A cingulotomy is an example of such a microsurgery and is an alternative to the no longer performed full lobotomy. Neurosurgeons use lasers to burn small lesions in specific areas of the brain. It is brain surgery, so it's serious and is a last resort, only used if nothing else has helped. But they don't make big incisions, and patients can usually go home the next day. It's most often used to treat depression, OCD, and chronic pain.